Welcome to the now weekly COVID-19 series from the Jewish Medical Association. It's a great pleasure to have as a guest, a colleague, member of the association, stalwart member of the association, Professor Alan Salemer from the Department of Renal Medicine based at the Royal Free Hospital. And of course, somebody who has, because of the work done in the Royal Free Hospital on the subject of COVID-19, who's probably one of the experts on the subject in the UK at this juncture. And I noticed that it's part one. Presumably, we're going to know whether that's part one because he wants to give another talk, or it's part one because it's phase one, and we're likely to have part two. Part two may be a second peak, or part two may be what happens to the kidneys. So with those questions, I'll hand you over to Alan.
Thanks very much, David. Now, part one was meant to be light-hearted. I'm hoping there won't be a sequel and no part two, as that's what happens in the second round. I'm also looking forward eventually to having talks that don't involve COVID, so getting back to that sense of normality. And then the only other thing I noticed when I was putting this together was that all the references are from 2020, so it's fair to say it's pretty up to date. Okay, so what I wanted really is to sort of describe what some of the experiences we've had from on the sort of renal department side of things at the Royal Free, and sort of put this in context, and just walk through some issues as it relates to the kidney and why the kidney gets injured with coronavirus infections, what's happened to our particular patients who are at high risk, both the dialysis and the transplant patients, what it did to our services, and what we're going to do next. Maybe that's the part two. Okay, so first of all, this slide shows you the bed occupancy, so the number of admissions at the Royal Free since the middle of March up until the beginning of May, showing you that we sort of peaked at just over 350 patients with coronavirus at the height in April. And that's both in the general ward and on the intensive care, which was pretty full and consistently full all the way through the pandemic. The red line on the left-hand side shows you when we closed our transplant program, and it will become apparent about the timing and what we've done since then. But it just shows you that at that time, we had about 150 patients at the Royal Free, and our anxiety was really that we couldn't be sure that we would have a safe environment for some of our immunosuppressed patients to stay, and therefore it was safer to suspend the program than continue in the hope that we could separate coronavirus positive and negative patients. So since you've been involved with these talks for a number of weeks, you'll know a lot of this background. I'm sorry if it's a bit repetitive, but the issue with this virus is that it's very varied in its presentation. For the vast majority of people, it will either be an asymptomatic or a very mildly horsey symptomatic illness, possibly with some upper respiratory tract involvement and maybe some loss of sense of smell or taste. But for a very small minority of people, it will be a very severe disease with multi-organ failure in some, and a very high mortality in those patients who have the most severe form of the disease. Depending on the series that you look at, kidney involvement can be present in about half the patients with COVID-19. And in the ones who have the most severe forms, renal replacement therapy, so dialysis, is often required. And if you reach the stage where you require dialysis and you're on an intensive care unit, the mortality of those patients, unfortunately, was as high as about 80%. So patients who had just kidney involvement was around 70%. Patients who had kidney involvement and were on a ventilator and or had any inotropic support, their mortality went up to about 80%. So renal involvement does portend a very poor outcome. How does this compare to other coronaviruses? So I've just tried to put a few features, and obviously we're focusing on the kidney, comparing these different epidemics that we've had: SARS in the early 2000s, MERS in 2012, and COVID-19. So this infection spreads much more readily. The mortality is lower, but because the larger number of patients affected, the overall death rate is extremely high. What's interesting with all of these coronaviruses is that kidney involvement is not uncommon. And kidney involvement as assessed by whether there's any abnormalities in the urine, so protein or blood leaking out in around half the patients, and then acute kidney injury where the function of the kidney decreases very rapidly, anything from not being present at all in some series to up to about 50% of patients with the illness. And then a proportion of those patients, especially the ones who have the acute kidney injury, just up to about 40% who need some form of kidney replacement therapy in the form of dialysis. The timing seems to be a little bit earlier, but that may be that this infection is more likely to be asymptomatic in these patients than with the other infections, and therefore the timing may not be a completely accurate reflection, or it may actually have a little bit more of an incubation period. So what do we know about the kidney involvement when the kidney stops working acutely? This is a very large series from New York of over 5,000 patients that showed about 37% of patients having some form of kidney injury. We can break down acute kidney injury into 3 different stages, which really reflects the severity as judged by how much the creatinine rises or how poor the urine output becomes. But just over a third of patients having kidney involvement with risk factors that are listed there. These are really risk factors that are present for all forms of acute kidney injury, and in a way reflect the lack of reserve that a kidney may have as we get older, as there is prolonged hypertension, or if there's persistent, or if there's diabetes, that the kidney can't adapt to an insult that it receives, and so it's more likely to have an episode of acute kidney injury. And as you can see from the little chart on the right, approximately 35% of people in this series who had any form of acute injury, so that's from the mild to the much more severe requiring dialysis, died. And it got to the extent the number of people involved who had the number of patients who had kidney involvement, mostly on the intensive care unit, got so much that actually one of the shortages that people started to notice, or one of the major impacts it had on our service, was that we were running short of supplies how to dialyze people on the intensive care unit and whether we could dialyze them. In New York, for example, they had a number of problems getting enough people dialyzed. There were shortages of replacement fluids. There were shortages of the plastic consumables that we use in the machines. And of course, there were shortages of staff members to carry out the dialysis. And this was true both in the US and in the UK, especially in London. One of the impacts that this had was that we ended up going back to sorts of treatments that we hadn't really done as an acute emergency, such as acute peritoneal dialysis, for over 30 years. And certainly one of the units in London, the King's unit, had a number of different patients who were put on emergency acute peritoneal dialysis, which was really something we hadn't seen for a very, very long period of time. It was sufficiently bad in the US that this story was printed in the New York Times of a man who had kidney failure and was needing dialysis, but couldn't actually get dialysis because there weren't enough dialysis machines available. He became severely hyperkalemic and had a cardiac arrest from his hyperkalemia, and only at that point did they institute acute peritoneal dialysis. So this was a very real and significant problem. And while we focused a lot on the ventilators, which were clearly what we worried about because we thought this was going to be a predominantly respiratory disease, the issue of adequacy of kidney replacement therapy was not really thought through. And I would say that we got away with it by the skin of our teeth. Okay, so acute kidney injury is very common. And one of the questions is why? Why is it very common? Is it simply a marker of people being unwell, or is there something else about the virus that has a predilection for causing kidney problems? In the early stages, because everyone was so concerned about this acute respiratory distress syndrome, I think there was a temptation to try and keep the patients relatively dehydrated so that there wouldn't be so much fluid that could leak into the lungs and mean that patients would need to be ventilated. In combination with the fact that there were lots more insensible losses through diarrhea, through fever, through using oxygen, which dries out the upper airways, I think some of the patients were actually volume depleted and dehydrated, and that was in part the problem with the acute kidney injury. But I think there's more to it. We know that there was more to it than that. One of the issues was whether these coronaviruses actually have some tropism for the kidney. Can they actually get into the kidney, and are they causing a direct insult? And obviously, if they can get into the kidney, they can damage the cells within the kidney itself. And there are examples of other viruses, such as parvovirus, that can do that. Or they can institute an immune response that then leads to a secondary problem within the kidney. And we've got lots of examples of viruses that can do that, such as HIV or the hepatitis viruses. Or sometimes viruses can institute an immune response where the cells, the leukocytes that come into the kidney, can actually cause the damage themselves. Just going back a tiny bit and understanding what the relevance of the viral tropism is, how the virus might get into the kidney. We know, and I'm sure this is something everyone's familiar with, but just to go over it, that the ACE2 receptor is required for the virus entry into the cells. ACE2 is present on a number of epithelial surfaces. The spike protein that surrounds the virus needs to be partially cleaved by this enzyme called TMPRSS2, which allows the epitope to be exposed so that it can bind the ACE2 receptor. And the ACE2, the virus then binds the ACE2 receptor and it internalizes into the cell, and it actually downregulates the amount of ACE2, which is important, and we'll come back to that later on. But suffice to say that you need ACE2 around for the virus to get in. So if you look at the kidney, these are sections of kidney that have been stained for the protein ACE2, and without bringing back terrible memories of everyone's kidneys pathology that they had to endure when they were younger, which is why they're not doing nephrology now. These cells that are brown, that are lighting up, these are all tubular cells. And you can see, I don't know if my pointer can show you this, but there are some glomeruli on the left-hand side of the section and on the right-hand side, and they're not really staining very much. There's a little hint of staining. So mostly it's the tubular cells that have the ACE2 protein. But we can now do some slightly more intricate analysis, and we can actually look at individual cells' RNA expression using this technique called RNA transcriptomics, which is really revolutionizing how we understand different cells work. And if we look at the kidney here, these are cells that are expressing the particular RNA for this particular, for the ACE2 protein. And the greener or the bluer the dots are, the more expression there is. And what you can see is that there is expression in the tubular cells, the distal convoluted, the proximal convoluted, the loop of Henle, and very little expression at the bottom there in podocytes. And that's a very similar expression pattern of the enzyme required to cleave the spike protein so that it can bind the ACE2. All of this is really to say that the machinery for viral entry into the tubular cells is there. What we do know when we were trying to think about why the kidney might be so particularly affected by this virus was, at least initially from the early studies in China, from post-mortem studies, unfortunately, because there were very few biopsies that were being carried out. And from these post-mortem studies, what we see is that the tubules are very severely damaged. Now, that's not uncommon in post-mortem studies because the very process of dying causes some tubular injury. There was very little else in terms of inflammation in some of the early post-mortem studies, but there were reports, and these electron micrographs here were reports of viral particles within the kidney. These have been disputed whether these are really viral particles. They look a little bit like sort of pictures of UFOs that you can sometimes see, but some people think they may be cytoplasmic components or infolds of endoplasmic reticulum rather than viral particles. Other post-mortem studies went on to try and stain for the virus, and this lower section here, which is immunofluorescence for the viral protein, seems to show that it's present in the tubules. And one or two other studies suggested that, in fact, there was a little bit more of an inflammatory response with mediators of complement and leukocytes being present in the kidney itself. So from these, we know that the tubules have been can be affected. We think there may be virus in there, although, as I say, there's very little evidence of virus coming out in the urine from most of the studies. But nonetheless, there's probably virus that can get into the tubular cells and instigate some sort of damage. The other cell, and this is the last bit of pathology, the other cell that can be involved is the endothelium cell, and there's some data showing that there's actually an inflammatory response within the vasculature, within the endothelial cells. And we think that this might be responsible for the increased thromboembolic disease that we see, myocardial infarction, pulmonary emboli, deep vein thrombosis, that seems to be much more common in patients who had COVID-19. And maybe not surprisingly, the ACE2 protein, the receptor for the virus, is also expressed on endothelial cells. So if the tubule is the main target of the virus in the kidney, do we see evidence of tubular pathology? And I think we do, but I think this has often been missed because many of the features of tubular damage can be seen in patients who are very sick, and there may be other explanations for why some of these abnormalities are seen. So I'm just going to show you two very quick cases, and I can see some people already sweating with fear from tubular physiology from 30 years ago. But this was a 52-year-old woman who was a diabetic who developed end-stage kidney disease from her diabetes and was lucky enough to have a combined kidney and pancreas transplant a number of years ago. It was unfortunate that she was admitted with a infected foot and an abscess that didn't really settle, and so the vascular surgeons considered that the only real option to save her was to perform an amputation. And she got through the operation extremely well, but a few days later she developed a cough and a fever, and she was positive for COVID-19. And 3 days after that, she developed a very severe metabolic acidosis. And these are her blood tests with a very low bicarbonate level, an extremely low phosphate level, and a very low potassium level, all of which is consistent with a Fanconi syndrome, meaning that the proximal tubule, where the reabsorption of all of these compounds occurs, was not working properly. And that was proven when we looked at the amount of phosphate and potassium that was being lost in the urine, and the fact that she had low molecular weight proteins leaking out, which normally get reabsorbed. So this, and this just shows the graphical changes in her parameters. This came on 3 days after her COVID and lasted for just under 3 weeks. And then a second patient who was a 65-year-old man who'd had a very dense stroke and was being peg-fed, who also acquired COVID within the hospital and developed this very severe jump in his serum sodium, holding on to his urinary sodium as much as he could, developed an acute kidney injury with a very big jump in his creatinine, very concentrated serum, but unable to concentrate his urine. So he had a nephrogenic diabetes insipidus, meaning he wasn't able to reabsorb water from the distal convoluted tubule and the collecting duct. Again, started a few days after COVID developed or was diagnosed, and took about 3 weeks to resolve on its own. So tubules are mainly affected. We've looked for non-tubular disease, whether there was something else that could have impacted on the podocytes and the glomeruli. We would expect to see a lot more proteinuria with these conditions. And there are a few cases reported, and we've seen one of them of patients who have a particular form of nephrotic syndrome where they lose a lot of protein in the urine. And these were predominantly in Black African patients who were predisposed to this form of nephrotic syndrome caused by something called a collapsing glomerulopathy, who also in 2 of them had genetic risk variants for this particular condition. This is something that we do see with other viral infections, and we do see with the hemophagocytic syndrome, which I'll come back to later on. So predominantly tubular abnormalities, some very rare cases of glomerular abnormalities. And then the final reason we think there's damage to the kidney and there is an acute kidney injury is that there are hemodynamic changes that occur. So back to this ACE2, this is a receptor that normally allows cleavage of angiotensin 2 to a less inflammatory form called angiotensin 1 to 7. Angiotensin 2 is very vasoconstrictive, is involved in increasing vascular permeability, whereas angiotensin 1 to 7 does the exact opposite. So We think local levels of ACE2 and local levels of angiotensin acting on particular receptors can influence the amount of vasoconstriction, which can then cause some ischemia and damage to the kidney. As the virus gets into the kidney, it downregulates ACE2, and if it downregulates the ACE2, there's probably more angiotensin 2 present to act through the type 1 receptor. So there's direct tubular involvement from the virus. There's possibly in some cases some inflammatory responses, although that's not been so well characterized. And there are at least theoretical hemodynamic changes that can occur within the kidney that can cause damage. So to summarize all of that in a sort of cartoon, the virus can get into the kidney. And that's also without forgetting that these patients may have sepsis of other etiologies. So they may have a secondary bacterial infection, they may have acute cardiac problems, and obviously they may have severe pneumonias that will cause hypoxia and hypotension, which also compounds the injury to the kidney. So acute kidney injury is multifactorial. It occurs very commonly with COVID-19, and it portends a poor outcome if it's very severe and requires renal replacement therapy. This brings me on to the question that, at least to begin with, we had a lot of debate about, and people were very anxious, patients were very anxious about whether they should or shouldn't stop their ACE inhibitors or their angiotensin receptor blockers, which obviously work on the angiotensin 2 pathway. And to summarize, quite a lot of work with a number of different investigators and thousands of patients that have been looked at. There is no increased likelihood of developing COVID-19, and there's no increased likelihood of having severe COVID-19 in patients who are on these medications. So our recommendation has been throughout that you should continue to take these drugs, but follow sick day rules, meaning that if you become unwell, which you should be doing, people should be doing anyway, if you become unwell, if you're not able to replace fluid, if you have diarrhea or vomiting, then you should temporarily stop these drugs, but restart them as soon as possible. Clearly less problematic if you're on these drugs for hypertension, but much more of a problem if patients are taking these for heart failure or for protection of the kidney. And a number of people who got in touch with us were very keen to stop them as a result of the fear and the sort of misunderstanding of what was going on. But clear evidence now that it doesn't make a difference if you're on them. So that's really the story of patients who didn't have kidney problems beforehand. What about our patients who had pre-existing kidney disease? These are data that have recently been published on 17 million UK GP data from 17 million patients from the GP primary care records, and associated 11,000, just under 11,000 patients who died of COVID-19. And this is a plot to really show the risks associated with each of the factors on the left-hand side. So the line down the middle, the red line down the middle, means that there's either an advantage or a disadvantage of that particular factor. So there's no increased risk with it. Anything to the right increases the risk of that, of death. In this case, this is death from COVID-19. Anything to the left decreases the risk. So the first thing to look at is the fact that age is probably the biggest factor. 50 is used as the reference point. Anything below 50 and you're protected from death from coronavirus. And then for every decade that you go above it, you shift to the right, increasing the risk significantly. But I want to focus just a little bit lower down on what happens with reduced kidney function. These data suggested that if you compare to patients who have no reduction in their kidney function, so normal kidney function, a GFR of over 60 mils per minute, or an estimated GFR over 60, if you compare the ones who have GFRs of 30 to 60, there's a slight increase, about 1.5 times risk of 50% increase of dying. But if you look at the ones who have GFRs of less than 30, that goes up substantially. So nearly all of our patients who have impaired renal function are at greater risk of dying from COVID-19. And in the middle of March, the NHS sent out letters to everyone who was considered to be at high risk, suggesting that they should shield. And that meant not leaving the house and maintaining extreme distancing measures throughout, which is fine for lots of people, but not really possible if you have to come to a dialysis unit 3 times a week, where you are sitting with other patients like you who are dialysing for 3 to 4 hours at a time. And you may also require transport to get you to the dialysis unit, where you share the transport with a number of other patients. So one of the biggest problems we realised was going to happen was what would happen with our patients who were requiring long-term dialysis. These are data from the Royal Free looking at the renal patients who are were admitted, who were positive, sorry, not admitted, who became positive with coronavirus during this period from the middle of March to the middle of May. And you can see that the top line is those patients who are on hemodialysis, suspected and confirmed, and the red line is those who are on hemodialysis confirmed by swabs. Whereas those patients who could stay at home, the transplant patients and those patients doing home dialysis with peritoneal dialysis, which is a home therapy, were able to maintain much lower rates of COVID-19 positivity. If we look within dialysis units, so these are just 4 of the dialysis units, you can see that there's a very different picture that emerges within the dialysis units. In one particular dialysis unit, a very sharp incline where almost 40% of our patients developed coronavirus or caught coronavirus, whereas in another dialysis unit, a much more gentle cumulative incidence of coronavirus, where it didn't even reach 20%. So there are differences within the different dialysis units, and we've spent a lot of time trying to work out why that should be the case, because a lot of the things that we do in dialysis are fairly regimented and are similar from one unit to the other. And we've looked at a number of different factors, the distance between the chairs, how we separated people onto shifts, and it's very difficult to tease anything out at an individual hospital level. So what we've done is we've established a pan-London COVID data database where we've actually got buy-in from all of the different renal units across London, and we now have data on over 6,000 patients who are on dialysis. And the data are almost out. We've almost got something ready to put out for publication, but essentially what we found is that the variations from one hospital to another or from one dialysis unit to another are not mostly accounted for by differences such as how far the chairs are apart, how many people are in the waiting room, how many people are on the transport you come with. They seem to reflect quite significantly the differences going on in the community outside where you come from. So higher rates in the community and higher rates in that particular dialysis unit. What's more is that it seemed that the community cases preceded the dialysis unit cases by about a week, possibly even 2, meaning that should there be a second surge, should we have to think about part 2 here, then we might get some heads up from the community transmission occurring to tell us that it's likely that that will occur within the next week in the dialysis units, when we can actually get our nurses to start wearing full PPE, for example, which at the moment is not practical for the long shifts that they're actually dialysing patients on. So variation within hospitals, variation within dialysis units across London, but possibly reflecting for the most part what's going on in the communities from which the patients came from. What is interesting is that the positivity on the swabs that we've got, that we've found, is probably just the tip of the iceberg. These are data from the West London renal unit from the Hammersmith Hospital, which show that they looked at just over 350 patients, and they found that over a third of them had antibodies to SARS-CoV-2, but just under half of those patients who were positive were either asymptomatic or had a negative swab. That means there were a lot of people on the dialysis unit who were possibly contagious, who either had no symptoms at all or were tested but had a negative swab. One of the other anxieties we had is that renal patients, especially patients who have end-stage renal disease, are relatively immunocompromised. So the kidney failure does mean that their immune system doesn't work quite as well as somebody who has normal kidney function. And we were concerned that actually one of the problems might be that these patients might not develop immunity to the virus. But from these data from the Hammersmith, only 2 out of the 79 patients who were positive on a swab didn't show a seroconversion rate, which is extremely encouraging, suggesting that dialysis patients can mount an effective immune response. Now, how long that lasts and how effective it is just remain unknown in the dialysis population as they do in the general population. So what about the other patients we've got? So we've got patients who are on dialysis, on hemodialysis. We've got patients who are on peritoneal dialysis, and we've got transplant patients, and those who have chronic kidney disease but don't require any renal replacement therapy at the moment. And these are very sort of sombering data, unfortunately, because what you'll see is that the the percentage of confirmed cases out of the total population, so about just under 20% of our hemo patients overall were confirmed with COVID-19. But we had, of those who were positive, we had a 30% mortality. Now that was similar whether they were on hemodialysis or peritoneal dialysis, although the number was significantly fewer. So that we had fewer patients who were positive who were on home peritoneal dialysis. We had fewer patients who were positive who didn't require dialysis but had kidney failure. And we had fewer transplant patients who were positive, but the mortality in all of these groups was more or less the same. So something about kidney failure per se, even if you replace it, even if you have a transplant, that puts you at slightly higher risk of dying. One of the issues was related to immunosuppression. We were obviously very concerned that our transplant patients who receive maintenance, regular immunosuppression to keep their organs working might be at much greater risk of dying or having very severe COVID than the patients who weren't immunosuppressed. And at least these data, and these data are replicated across the country, don't seem to suggest that the immunosuppressed patients who got COVID did any worse than the patients who weren't immunosuppressed and got COVID. Which brings me on to another issue. And again, I just wanted to use this example just to discuss this issue of immunosuppression and inflammation. So this was a 48-year-old man who had been on dialysis for 4 years because his kidneys failed due to IgA nephropathy. He had his transplant call on the 19th of March, which is normally a very happy event. He came in, he had his kidney transplant, and we were keen to try and get him out of hospital as soon as possible. So 4 days later, he was back home having had a very successful kidney transplant, which was working well. Unfortunately, he was readmitted a week later with symptoms of coronavirus, with a cough and a fever, and had a very rapid deterioration to the point that he needed to be intubated on the intensive care unit. And you can see his x-rays on the panel below, which go from his time of admission to when he was on the intensive care unit and intubated, and then gradually recovering. And a CT scan that shows you that his lungs have completely recovered, this taken in July of this year, with only very minor scarring in the top part of his lungs, so a complete recovery. But what this case really exemplifies is that despite being very heavily immunosuppressed, about 3 weeks after he had all of his heavy immunosuppression, he developed a hyperinflammatory syndrome, which is something which is similar to a hemophagocytic syndrome, with lots of inflammatory markers suggesting that he had an overactive inflammatory response. And at a point when we thought he was highly likely to die, we started him on some treatment with a monoclonal antibody to block the cytokine interleukin-1, which is one of the key inflammatory mediators. And following that, you can see these graphs. Following institution of that, all of these lines seem to normalize. So his inflammatory response, as exemplified by his CRP, his fibrinogen level and his ferritin levels, seem to come back down to baseline. And he's been left with an extremely good kidney function with a lovely graft that's functioning, but managed to mount a very severe inflammatory response despite all of the immunosuppressive therapy he was on. Now, this has been noticed in a number of patients. And in fact, some of the early markers of poor outcome in COVID-19 relate to some of these inflammatory markers. So the more severe the inflammation, the worse patients did with COVID-19. So markers such as CRP, ferritin, and cytokines such as IL-6. Hemophagocytic syndrome can be a primary immune deficiency abnormality that leads to it, but it's most often due to sepsis, most often due to viral sepsis, can be due to other autoimmune diseases or malignancies. And there have been a number of cases now of very severe hemophagocytic type syndrome occurring in patients with COVID-19. And there are ongoing trials at the moment of anti-inflammatories, immunosuppressants, such as anakinra, such as monoclonal antibodies to block cytokines, IL-6, as well as high-dose steroids or IVIG to try and combat this. So there's a slight paradox here, which is we were really worried, and we still remain worried about the role of immunosuppression in patients, putting them at increased risk of developing COVID and developing severe COVID. But we don't see an increased mortality in patients who have caught COVID who are immunosuppressed. And we actually now think that some of the treatment, some of the immunosuppression itself may be of benefit in people who have the more severe form of COVID. So as you will all know, the large UK recovery trial has shown that dexamethasone, a very effective immune suppressant, is actually the best and really the only effective treatment we've now got for severe COVID-19. So there is a slight discrepancy between what we think immunosuppression might be doing and what the data show, and I think it remains unclear. There are some data from other branches of medicine, so rheumatology, for example, where a lot of immunosuppression is used. And this is a large series that was recently published with some UCL colleagues, looking at over 600 patients who had rheumatological diseases, very varied conditions, but mostly rheumatoid arthritis, lupus, or psoriasis. Just under half of them were, all of whom had COVID-19, half of them were hospitalized, and just under 10% of them died. But the risk factors for hospitalization, so I'm not talking about mortality now, but for hospitalization, were really only found to be using a dose of prednisolone, so a steroid, more than 10 milligrams a day. The other immunosuppressants did not seem to be associated with an increased risk of hospitalization. And in fact, some of the immunomodulators, immunosuppressants that we use, for example, TNF blockade, actually seem to be associated with a reduction in the need for hospitalization. So on the one hand, we have these data suggesting that patients who are on prednisolone more than 10 milligrams a day are at high risk of being hospitalized. And on the other hand, we have data from a very large randomized trial that says giving high doses of dexamethasone once you are hospitalized improves your outcome. I think we need to get a little bit more understanding of what it may be a timing issue, it may be a dose issue, it may be a genetic predisposition for hyperinflammation that we still don't quite understand. But there's something very curious going on in a subset of patients who develop, despite their treatment, a very severe inflammatory response. And I think we now have means of treating this, which will hopefully translate to improved patient outcomes. So I told you about the impact on dialysis services on the intensive care unit. The impact on transplantation was pretty devastating. These are data from the UK, looking at the number of transplant centres that remained open with the dates on the x-axis there. And you can see that number of transplant centres was reduced to just about 3. One of those was in Northern Ireland, where the number of COVID-19 cases was extremely low. They had very, very few community cases of coronavirus, and so they were able to carry on transplanting throughout. And then there were a couple of other centres in England that carried on transplanting despite the pandemic, some of whom had separate hospitals where the renal services were being carried out, meaning that they could keep patients slightly separate from the rest of the hospital. Our feeling was that through a lack of being able to test all the patients who were in the hospital, to really understand how many patients were positive and not really understanding at the beginning of this pandemic how spread was going on and how many asymptomatic patients there may be, we chose to close our program down. And the case that I just illustrated was really reinforcing our decision that that was the right thing to do to try and minimize the risks to other patients. Now, whether that would have played out in the same way or not, we're not completely sure. The impact it had on staff was quite substantial. One of the dialysis units we almost had 80% of the staff at one stage being sick. There were huge degrees of anxiety and uncertainty, not only about what we were doing for the patients, but what we were doing in terms of our own risks going forward. I think it was probably one of the most anxiety-provoking times that I can remember in terms of really not knowing how this was going to impact on the staff and how many staff members may or may not survive this particular pandemic. So there's been a lot of talk since then. I think we've all become a little bit more blasé about it, but and we've had a couple of sessions of debriefing staff with our clinical psychology team to sort of try and talk through some of the experiences that people had during that time. But genuine sickness occurred very commonly, and it stretched the services so that people who really sort of rose to the task ended up doing a lot of work beyond the call of duty. The interesting thing about the coronavirus is that I think it highlights some other aspects of diseases that we don't really understand. So in the last global pandemic in 1918, this pathologist, Ernest Goodpasture, described a condition which we now have as an eponymous syndrome called Goodpasture syndrome, which was named after him, where patients presented coughing up blood with lung hemorrhage and acute kidney injury. This was a form of vasculitis, of inflammation in the blood vessels, which he was convinced was due to the virus itself. He thought this was due to influenza stimulating this response in the lungs and in the kidney. Now, we now know a lot more about those conditions than he did back then, and we know that actually those are autoimmune conditions. But what's interesting was that during this pandemic, we saw very little of those conditions that we normally see in our service. Now, some of that undoubtedly was because patients were too scared to come to hospital and may have very well come to some harm staying at home. Some of it has been hypothesized that it may be due to the fact that certain environmental triggers were not present because people weren't exposed to going outside to the same extent, so they weren't exposed to some of the same viruses or the same environmental toxins that might trigger some of these autoimmune diseases. And some of it may be that we aren't very good at differentiating some of these autoimmune diseases from infection with the virus itself. And some of these conditions have got striking similarity with coronavirus infection and severe COVID-19. The hyperinflammation, the prothrombotic tendencies, the bleeding from the lungs and an impact on the kidney. And I think we're going to learn a lot more about some of these autoimmune conditions and the impact that coronavirus may have had either in triggering them or in keeping people at home and preventing them from happening. But that's something that we need to think about in terms of serological studies in the time to come, looking at these autoimmune conditions. So here's part two. What are we going to do if this comes back? And obviously there's a lot of debate about when and if it comes back and how it's going to come back. We've started to prepare intensive care units. We've increased the capacity of our intensive care units and our capacity to deliver renal replacement therapy on those intensive care units. I think we're better at recognizing the renal abnormalities early on, perhaps optimizing what took us a little bit of time to figure out during this first wave of a pandemic, figuring out how to treat it sooner so that we don't run into problems in the same way. And we're now really much more aware of this hyperinflammatory syndrome that we think probably accounts for a significant amount of the mortality. And thankfully, we now have a treatment that, or a series of treatments that we think could actually reverse some of this hyperinflammation. Now, that's not to say that we can be complacent and think that we've got this under control, but we certainly have got evidence now that we didn't have 6 months ago that can steer us in the right direction for treating the patients. We might have some early warning signals in the community, which will allow us to understand what's likely to happen in the hospitals in a week or 2 weeks' time, which might mean we can gear up in a particular way and react to that community increase appropriately. We've got some idea about shielding, which has now been modified. Obviously, the shielding process in the UK has been officially ended, but there are recommendations. These are recommendations, for example, from the Renal Association of the UK, looking at different patient groups and what we might recommend to them in terms of their ability to go back to work, their ability to interact with other people, or the need for them to stay at home as much as possible, given the constraints that they've got. And you can see it's a sort of traffic light type approach. Age, clearly a very important factor along the top. So the younger you are, the more likely you are to be in a green or yellow or an orange box. But obviously the patients who are older, who have any of these other risk factors, so essentially any other form of kidney involvement, if you're over 70 years old, the recommendation would be to ideally carry on working from home and try and maintain as much of a quasi-shielding approach as possible. The other impact, so what have we done in part 2? We've restarted transplantation. So we had about a 4-month break where we, till we were happy that the community cases were at a sufficiently low level, that we had very little in the hospital. We established a sort of COVID, as secure as it can be, a separate transplant ward where we require patients to have a negative swab before going into it. So we're doing rapid COVID tests on the day of the transplant, we're calling patients in, screening them. We've managed to do more transplants in the last 4 weeks than we have done in the similar time period last year. And so far, so good. Is this surge proof? Will it resist a second wave if it happens? I'm not sure that the system is robust enough for that, but at least for the time being, we're pretty confident that things are going well. And we took advice from patients. We asked them, were they keen to restart transplantation? I mean, for many patients who were waiting, some had kidney transplants already lined up from prospective living donors that had to be cancelled, and obviously some people were put back onto the waiting list or remained on dialysis whilst there was a degree of uncertainty about when we might start. So we've re-established living donation and we've re-established cadaveric donation, and so far so good. So I think I've probably gone on for too long. So kidney involvement is common. It's not just a lack of fluid, although as we tell our students, that never really helps. It's predominantly a tubular injury, and that I sort of went through some of those mechanisms. It's probably a direct viral effect and some other coincidental effects from being very sick and from some hemodynamic changes. Patients who have kidney disease are at much higher risk of COVID. I think the shielding clearly has had an impact, and certainly when we look at our transplant patients who've been affected. And there's a big question about immunosuppression, which I don't claim to understand, but I think we might get some further insights down the road about what the relative risks of immunosuppression are. But for the time being, we are assuming that it does increase the risk, and we are dealing with patients appropriately. So, so with that, thanks very much, and have a good night. I can't hear you, David, sorry.
Thank you very much. And we have several questions have been coming in as we've gone along, and I'm going to fire them at you. One of them was the question that is this a glomerular vasculitic or a fluid balance problem? And you answered that in the final slide, that it's you think it's a tubular injury problem.
Yeah, there's no real evidence for anything else apart from, I mean, very few patients with anything else apart from tubular injury. Yeah.
But the absence of any information in the slides was very striking.
Yeah, and I think that we've still got we're trying to collect biopsy samples from patients. There are sort of global attempts at getting series of biopsies together to see what the incidence of other pathologies are. But so far, nothing really very dramatic has been reported apart from tubular damage.
Well, thank you very much anyway for the plug for the importance of pathology, which which of course I much appreciate, but that's a personal comment. What is the question about the staging of chronic kidney disease? How, kind of, when you've got patients who've got this and they're going on to chronic kidney disease, and conversely staging chronic kidney disease, increasing the incidence, as you said, of people with renal disease
Yeah. So, I mean, I think the problem is as your kidney function goes down, there are lots and lots of other things that happen as a result of that. So your vasculature changes. We know that the risk of cardiovascular disease goes up as your kidney function goes down. We know that your cardiac function changes. So the chronic kidney disease is really a marker of lots of other things that are going on in different organ systems. And I think why chronic kidney disease gives you such a higher risk of not doing so well is probably not just to do with the kidney, but to do with all the other vascular beds and the other organs that are affected as a result of that.
Right, and there's another question, and conversely the other way around, from also from Victor Selwyn, about if you've got if you're 70